know
Well,
it
I
was going to
think
be so
once-
informal.
Well,
I was preparing mentally for
we're
a lecture, but I'm not going to.
we're going to be very relaxed here. So I'll introduce you, and then maybe if you want to just start by having people introduce themselves, just
Oh, yeah, that'd be
since
great.
it's a small group.
And will the coffee keep flowing?
You bet.
Brief welcome first. Yeah.
Yeah. So good morning, everybody. Thank you all for being here. We're glad you made it through the snow. I want to introduce Sandy Johnson. She's the president of the National Press Foundation, to give us a brief welcome.
I just want to say welcome, everybody. We're glad you came out on a cold Monday morning. The National Press Foundation is a nonprofit. Tom. Sorry. We're getting started here. Sorry, I know Tom Donlin. So. The National Press Foundation is a nonprofit, and every dollar that we raise goes to programs like this to educate and train journalists. So the staff has worked very hard to put together a wonderful array of speakers, including Dr. Waldman. And we want you to listen and learn and share this with your audience, because every M.P.H program is on the record. So thank you, and I'll turn this over to Linda.
Great. So we are going to start this morning with Dr. Waldman. He's a professor of global health in the Milken Institute of Global Health at the George Washington University. He has worked on smallpox in Bangladesh. He's worked with refugees in Somalia. He's worked on programs for child health and survival with WHO and CDC. He's been in Ivory Coast. Dr. Waldman was WHO's coordinator following the tsunami in Indonesia, and also the U.S. government's health sector coordinator in the Haiti earthquake relief effort. All of this he's done interspersed with an academic career in which he helped to establish the relationship between aspirin and Rye syndrome. And for those young people among the group, you can ask him about that later. It's really a fascinating element of research. He was also professor of public health at Columbia. And so we are very pleased to have him with us this morning. He's going to talk about measles, everything you always wanted to know and more. So thank you, Dr. Waldman.
Thank you very much. I didn't know what to expect this morning. Well, except I didn't know what to expect when I got to the red line, and I got what I expected. But other than that, I thought if the trains were backed up that there was a prayer for the escalator, but no. But so here we are in a small, relatively intimate group. Is it okay to have people introduce themselves then?
Absolutely.
So you heard a little bit about me, too much, I'm afraid, and please don't ask me about Rye syndrome because it happened so long ago. I really don't remember very much about it. But is that okay? We go around the table.
I'm Joanna Colburn. I'm the manager of continuing education at the National Foundation for Infectious Diseases.
I'm Bob Myers. I'm a health journalist.
Hi, I'm David Hodis. I'm a business journalist working for different magazines, just out of curiosity.
I'm Tom Donlin. I'm the editorial page editor of Barron's magazine.
Sandy Johnson, president of M.P.H.
Kimberly Leonard, healthcare reporter with U.S. News and World Report.
Hello, my name is Vitek. I'm a student journalist from the University of Maryland.
And I'm Laura Helmuth. I'm the Science and Health editor for Slate Magazine.
Great. Well, thanks. Thanks for coming. Because it's a small group and not really formally, I'm not at a lectern standing up. I do have a class this afternoon of 3 hours, so I'll be lecturing there. So maybe we can do this much more informally. And I have a presentation prepared, and I'll go through it. But please interrupt. Please feel free to change the topic. I digress enormously while I'm talking. I have no idea usually exactly what I'm going to say, even with the slides. They're just jumping off points for me very frequently. And I've been asked to talk about measles, but if there are other topics of interest, then I'm happy to entertain them. I've just returned from Liberia and Sierra Leone last week. I'm pretty heavily involved in the Ebola response, and there are some parallels to be made there. Not necessarily that many, because I think that the idea of having this session on measles is stimulated by the current domestic outbreak. I will talk a little bit about measles in the global setting as well, both historically and in the present. There are a number of other really qualified people speaking for the rest of the day, Laura included. I'm going to try. I only have the basic topics of their the titles of their talks. I'll try not to step on their toes too much, but I will not succeed at doing that. And I've been told that since I'm first, they have to adapt to me, which is fine. So that's good. So measles. Most of the talk will be about measles. Some of it will be about other things. But I do think it's important that we understand what measles is, what the disease is, what it looks like from a doctor's perspective. And we can talk about what it looks like from every other perspective as well if we want. If I don't know anything, I'll let you know. If I feel ignorant on a particular topic, which is maybe most of them, I'll let you know. But we're here basically. I need to do this. I guess we're here mostly because of the outbreak that was reported in people who had visited Disneyland in December. It represented a pretty important spike in the number of cases that occurred because we do a lot of our reporting of diseases on a monthly or on an annual basis. And the outbreak started in 2014. It's a little bit difficult to gauge from the graphs about what happened last year and what happened this year. But there are plenty of, there's a lot of information on overall trends. I'm going to let, if Ann Shuckett's going to be doing a webinar, I'm going to let her talk about that. She's the head of the vaccine center at the CDC and is much, much more on top of the everyday trends and tendencies and the current epidemiology of measles in the U.S. Just to say that CDC releases its updates on communicable disease and on outbreaks on Mondays. And so if I have data to present regarding the measles outbreak, it'll be a week old and maybe even a little bit more because last Monday was a holiday. So we get caught up a little bit in that kind of reporting. Okay, I'm going to start then with a little bit of history. This gentleman is a man named Peter Panem, P-A-N-U-M. And he, when he was younger than he is in this picture, and he did have a very, very long and distinguished career as an epidemiologist. He's one of the fathers of epidemiology, which I guess has more than one father. But he was sent as a young man, just having finished medical school. He was sent by his government, the government of Denmark, to investigate an occurrence in the Faroe Islands, F-A-R-O-E. And he wrote a book about it that seems to have replicas available on Amazon. And this book is now a classic. I get confused. This is a classic in public health, his observations that he made. What happened is that there was an introduction of measles to the Faroe Islands in 1846. And the Faroe Islands are a place, they're here. Pretty foreboding and a remote place. They kind of belong to Denmark. They're considered to be Scandinavian. And it's a really, really beautiful place. It consists of about several hundred of these little communities spread over a large number of islands. And what happened is that measles was introduced into one of them. Measles that hadn't been present or reported from these islands in more than 65 years prior to 1846. So Panem went and he was able to do an investigation in which he could basically census the entire island, study a large number of these small isolated communities, which allowed him to basically observe the natural history of measles as it occurs in a naive population. And based on his observations, he learned that book, and many of his findings remain to this day very accurate. So there was a total of 7,000 some odd people living on the islands, and out of those 7,000, because there hadn't been measles there for 65 years prior, he was able to enumerate 6,000 cases of measles across all ages. Not quite, not all ages, because you can see that people who were 65 or older were entirely spared, and therefore Panem hypothesized that once you have measles, you cannot get it again during your lifetime. You have lifelong immunity. And that has proven to be indeed the case. He was also able to show to measure the time from when a person entered a village that had previously been uninfected, what the incubation period was until the time that people began to fall ill with this disease. So he calculated the incubation period at 10 to 14 days. He did not, but subsequently, based on the number of deaths that occurred in the population, a calculation was made that estimated the death rate to be 23 deaths per 1,000 population during the course of the epidemic. That's a very, very high number. So these observations are really interesting and hold true until today. And what the remarkable thing really is that in 1846, these people had no idea of germ theory. This was before Thomas Koch's time. This is a piece of work of shoe leather epidemiology, as they like to say at the CDC, that's really fascinating and remarkable. It's deductive, it's empirical, and it's entirely done without laboratory support and without even a knowledge of how the disease itself worked. It's only an account of what happened to the people. The leading theory of disease at the time was called the miasma theory, and that is that there were these airs, vapors, that somehow enveloped and engulfed the population, and people would get sick by breathing in these vapors. That's where the word malaria comes from, right? Bad air. This was the leading theory also in the 1850s, the following decade, when cholera swept through London. And similar kinds of observations were made about cholera by John Snow, and that have been written up in a number of really fascinating books, one of them being Ghost Map by a writer called Stephen Johnson. But Snow on cholera it's very similar in many ways to Panem on measles, where a physician, an epidemiologist, and Snow was the anesthesiologist to Queen Victoria and delivered her babies. On the side, he practiced sort of kind of infectious disease control, but he really elucidated the history of those cholera outbreaks in London and traced them back to a single source of contaminated water, which was pretty remarkable. Didn't know anything about bacteria, viruses, parasites. Microbes were completely unknown. Germ theory wouldn't be developed until the 1860s. So these guys were able to do all of this empirically and just report their observations. Many of them were attacked as being, the medical establishment thought that they were crazy because they challenged the existing theories of disease acquisition. But so Panem says in his book that there was not a single one of those 6,000 cases in which it was justifiable to attribute the infection to a miasmatic origin, while at the same time it was everywhere clear that the disease had spread from man to man. Just to say that an infectious disease, that this disease was communicable from person to person, is a major refutation of this miasmatic theory. And it's really important because this is the way we control infectious diseases today. I'm going to talk a little bit towards the end of my remarks about the smallpox eradication program, but I can say now that this is what's going on in Ebola control right now. Ebola has been, because the international response to Ebola was so late, it really has been as if there was a cloud of this virus over the 3 countries that are affected, and cases would occur here in a village and then there in a village, and you couldn't really discriminate. You couldn't isolate discrete chains of transmission. Now that the number of cases is reduced, that's exactly what we're doing in Liberia and in Sierra Leone and in Guinea, is tracking down individual chains of transmission. One of the indicators of success, even as cases continue to occur, is that we understand the provenance of each and every case. We understand its genealogy. And if we do that, then we can get a much better handle on where it will be spread and where it will happen next by tracing contacts of source cases. That's what Panem did in 1846. He traced all of these cases from person to person and was able to say definitively that it was clear that the disease had spread from man to man. Now, diseases can spread in many different ways from man to man, or that's the way they said it in those days. Women are involved also, and children are involved, of course. So I just wanted to say that now we do understand now that these diseases are caused by microbes. They can be caused by bacteria, by viruses, by parasites. This is a three-dimensional schematic of the measles virus. It's a member of a family of viruses called paramyxovirus. Its genetic base is RNA, it's a difficult virus to deal with in many ways. It's a fairly large family of viruses that has animal analogs. In fact, this virus undoubtedly evolved many years ago from an animal host and has adapted itself to humans, the same way as Ebola has evolved from the animal kingdom. Many, many infectious diseases have their origins in the animal kingdom. I don't know how many of you are pet owners, dog owners, but canine distemper, against which all of your dogs ought to be vaccinated, as mine are, is a very measles-like virus. And I'm going to talk about another disease also caused by a paramyxovirus called rinderpest, the disease of cattle, that has absolutely decimated agriculture and livestock owners and animal husbandry for centuries. We'll talk about that again towards the end of my remarks. So this is a virus, and here's what happens. And Panem observed this, and this is what still happens. Measles is a disease that occurs, as we said, 10 to 14 days after exposure to someone else who has measles. And then the patient, the individual, develops a fever that I'll show you in a minute, that the fever begins relatively low, at a low level, but increases very rapidly over the first few days of illness and then begins to subside. And cough, runny nose, looks a lot like a cold. Cough, runny nose, sore throat, conjunctivitis, or reddening of the eyes. The doctors like to say, oh, well, there are these Koplik spots on the inner side of the mouth. They're not always there. They're not easy to see, but they are. When present, they say that they help. It helps make the diagnosis. And then this sort of early cold-like syndrome is followed by the eruption of the rash. We like to talk sometimes about the 3 C's of measles: cough, conjunctivitis, and then these things is fever, runny nose, sore throat. It's what we all get when we have a cold, and the medical term for that is coryza. So we like to talk about the 3 C's: cough, coryza, and conjunctivitis. So there are stages of measles: the incubation period, or the prodrome, after the infection, the incubation period rather, after infection, no symptoms. The virus is kind of building up. Is it me? Yep. The virus is building up in the body. It's invading cells, destroying cells, replicating, but it hasn't been produced any symptoms yet. Symptoms then begin, this nonspecific 3 C's, the prodrome of the illness, and then we get into a phase of acute illness and rash as the fever develops, and then a period of recovery and convalescence, which is a pretty important period for measles. So here's a picture of the rash. This is a kind of very typical presentation. The rash usually begins on the head and progresses down to the lower parts of the body. Oh, sorry. I'm looking at it online because I don't want to turn my back. So this is a pretty typical appearance of the rash. It can it can be, it spreads down the rest of the body, over the chest, the trunk, the legs, all the way. And it can get fairly severe, in fact, and become entirely confluent over the body. So it can be pretty scary. The whole body can turn this flame red, actually. It's interesting that we don't see this anymore in the United States. So people call it now grandmother's disease, because only older people really have ever seen it. I guess that some of you here may have had measles. I have as well. But since the early 1960s, we'll talk about that, and you'll see on some of the graphs that there's been a remarkable and precipitous decline in this disease. Doctors don't see it, and that can contribute to doctors haven't seen it, so it can contribute to a delay in the diagnosis, actually, when it occurs in places like California or any place else where it might occur. So this is basically encapsulates the clinical course of the disease. You can see at the top is the fever, which can reach 40 degrees centigrade, which is pretty high. But you can see it starts off at a lower level, increases rapidly, and decreases. The rash develops on about the 4th day of illness and persists for about a week, a little bit less than a week. And that's really the time when people are most infectious. People are infectious for 4 days prior to the rash. So even during that period of non-specific symptoms, that's when a lot of spread occurs. So people may not know that they've been exposed to measles because the person who is the source of their illness won't have the characteristic rash. They'll just have cold-like symptoms. And you'll see in a minute that people really don't know when they're exposed very frequently because of the type of transmission that occurs. But the infectious period is really from about 4 days prior to the development of the rash until about midway through the persistence of the rash. So for about a week-long period that covers a few days prior to the eruption of the rash and a few days following the eruption of the rash. The conjunctivitis, the cold symptoms, you can see they last for about a week into the illness. Cough can be a little bit more persistent, but this is a good depiction and a good summary of the clinical course of the disease. There are complications to measles that can be quite important. Some of them are very common. Ear infection, and this should not be taken lightly. Infections of the middle ear can occur. Reasonably frequently, I'm putting down some of the minimum incidence levels of these complications, about 10% of cases. Diarrhea, about another 10%. Ear infections will require antibiotic therapy if they get secondarily infected by bacteria. Otherwise, they just have to run their course because there's a viral illness and there's no specific treatment. The diarrhea is really important, especially in developing countries, because it can be severe enough to induce dehydration. And it's actually the leading cause of death from measles in many developing countries in younger children who become dehydrated and aren't rehydrated aggressively enough. And then mortality in developing countries and poorer countries can be quite substantial from this disease. There are severe complications, pneumonia. Viral pneumonia is a very difficult disease to deal with. Sometimes the virus, because it spreads throughout the body, can also affect the brain, a condition we call encephalitis, or an infection and inflammation of the brain. And that can result, depending on which areas of the brain are affected, in generalized seizures, convulsive disorders, and in deafness. And that's obviously a lifelong condition. Measles, I wrote that here that measles was the leading cause of blindness in children, and I wrote 2004 because that's the last time I saw that statement made of measles being the leading cause of blindness in children. But I don't know, because the incidence of measles worldwide has been declining, so I don't know if that's still the case or not, but it is an important cause of childhood blindness, which is also obviously another permanent condition, as is death, which occurs in about 1 of every 1,000 cases. Yeah, did you have a question?
Have there been any deaths in the U.S. in
No.
the last 50 years? No.
In the last 50 years?
Mm-hmm.
No, I'm
Or
not sure.
since the vaccine?
I'm sure that there have, I don't have the data at my fingertips. You could ask Dr. Shuckett. In the last 50 years, I'm sure there have not been since in this century.
So
You'll see why in a minute I say that I'm not sure about the last 50 years. Yeah.
Does an infection in childhood lead to hearing issues in adulthood?
No. This is caused directly by the viral attack on the body, if you will. But there is another condition that I just want to signal, it's not so important, but there is a long-term complication of measles that has this ridiculously long name called subacute sclerosing panencephalitis. And this we don't really understand, but this is an illness that's related to acute infection with measles, but that occurs later in life and is not, it's apparently not directly related to the persistence of measles virus in the body, and we don't really understand what happens. But this disease definitely occurs and is definitely related to measles. It occurs, as you see on the slide, about years after full recovery from the acute infection, and it's invariably fatal. It's a very odd condition. It's kind of a slower inflammation of the brain, and just it's not well understood, but it's fairly rare. I used to, when I was in medical school, they used to teach us that this occurred once in 1 million cases. But now that surveillance has improved and that people are more sensitive to these kinds of diagnoses, it occurs more frequently than that, but still fairly rarely, and we wouldn't really know. And I'm sure a lot of cases are missed also, because people don't take complete histories like this. But it's much less of a problem now because there's so much less measles around. There's just measles is really becoming a relatively rare disease. It's a shame that it occurs at all, and we can touch on that later as well. But so I just wanted to mention that this exists. In regards to the treatment of measles, there isn't any. It's a viral disease. There's only supportive treatment that consists of hydration, maintaining nutrition. If there are joint pains or soreness, then Tylenol or other medicines like that. I would never say to give aspirin to children, obviously, because of my own involvement with Reye syndrome. And interestingly, the severity of measles really is much greater in those children who have vitamin A deficiency, which is many children around the world. And some South African researchers about 10 years ago, maybe more, showed fairly conclusively that including vitamin A supplementation in the treatment of measles led to much better outcomes. There's a little bit of a discussion about why this might be. Vitamin A, by the way, is also very highly correlated with blindness, vitamin A deficiency. So there's a form of blindness that's due to vitamin A deficiency that is a complication of measles. But much of the measles blindness occurs from viral infection of the optic nerve as well. So it's not only from vitamin A deficiency, but it's an interesting finding. There's very little vitamin A deficiency in the United States, so we don't have to deal with it. I don't practice clinically, so I don't know if doctors routinely prescribe vitamin supplementation for children with measles. I just don't know. But certainly in developing countries, one would add vitamin A to the treatment regimen. Then there are some people say that what happens is that when you're, sorry. Some people say that because this is an illness that affects the body, that it requires a great deal of energy and micronutrient supplementation during the recovery phase as well. So vitamin A is stored in the liver, and you get a lot of depletion of vitamin A. So it's not just for people who are starting off with vitamin A deficiency, but the fact of having measles can also result in a depletion of vitamin A stores in the liver during the convalescent period. So again, we always in the global health arena recommend vitamin A as part of the treatment of measles. So let's move to the transmission. This is a summary of the way diseases are communicable from one person to another. And I've kind of listed them in general, but there's airborne transmission, Droplet transmission, I'll come back to those two. Obviously, sexually transmissible diseases. We have diseases that are contracted either directly from contact with animals or, as I mentioned, many diseases are zoonotic or have their origin in animals, or that are acquired from insects, either directly or with an insect being a vector of disease from a different host. Foodborne, waterborne diseases we know about, and there are a lot of diseases increasingly these days that occur in healthcare settings. So I wanted to distinguish really between airborne transmission and droplet transmission, because measles is an airborne disease. That means that it can be spread far and wide through the air. So there's a big difference. For example, some of you might have seen late last week, there was a lot of fanfare around Ebola. Is it airborne? Is it not airborne? Ebola is not an airborne disease. But Ebola virus, because it's everywhere in the body, if somebody coughs, for example, and droplets of sputum or mucus are spread, then there can be virus on that. But when we talk about an airborne disease, we're talking about really someone coughing and the virus being spread out quite far on the air, actually riding, if you will, on particles that are coughed out. The virus can also settle as these on surfaces and survive on surfaces, but not for long, for a couple of hours. We know that Ebola can do that also. I tried to find, and I thought that I had seen a slide that actually looked like this, but that showed the difference between this kind of airborne transmission. I mean, look how far these droplets are flying. I mean, this is like 10 meters these are going to go. You just have to be, that's why I say that people don't always know that they've been exposed to measles, because somebody could be across the room, down the street, and and able to spread the virus really far. With Ebola, you can't. With Ebola, you would see the droplets would just, fall very quickly, and it's kind of practice in Ebola land to not come closer than 1 meter to another person, because that's about the estimated distance of spread that would be possible. But measles is very definitely an airborne disease as opposed to a droplet spread disease, so it's highly infectious. And that leads us to this slide that also has brought this term R0 into the vernacular, together with a movie Contagion, where I think Kate Winslet gave a whole lecture on the R0 concept, where it's just R0 is the degree of transmissibility of a disease. It says here it's the number of people on average that one person with a disease can infect. So the risk to others, and you can see the difference in these diseases, that diseases like Ebola are really, we've said this over and over again and tried to explain it to people, but it's not a very communicable disease. It's a very serious disease because a high proportion of people who get it will die, but it doesn't spread very easily because you have to be in very close contact, very close proximity to someone with the disease, and it spreads most easily when there's direct contact with a person with the disease. Whereas measles is one of the most infectious diseases, one of the most communicable diseases we know. And the R0 of measles is 18, it says on this slide, because it's spread easily through the air. And it's important to understand, on the other hand, measles is not as serious a disease. The case fatality rate is much, much lower, but still significant and substantial in some circumstances, and particularly in poorer countries. So I think that's a pretty important concept. Now here's another picture of the way diseases can spread, actually, which, and this picture was taken in regard to swine flu. Most people don't get swine flu this way. I get it a different way. But it's what's really interesting, and what I always like to point out, is that this sandal back here, I am told, I really don't know, but I'm told that that sample belongs to an epidemiologist at the CDC whose kid this is. Which is not exactly right, but I think it's important to. You don't have to be doing this to anybody to get measles or influenza for
And
that.
can measles be in animals or?
No,
spread-
no, the measles
Okay.
virus it evolved, undoubtedly evolved from animals, but the measles virus that we have is really highly specific to humans. So it's actually an important point to make, but there's no animal reservoir for measles. And no other reservoir, actually. You know, viruses can only live in living cells. The viruses don't have the machinery to reproduce themselves, so they need to hijack the genetic material of living cells. So some of them can do that in different species. Sometimes viruses are closely enough related that that infection with of an animal virus can provide protection against human disease, and I'm going to talk about that in a couple of minutes. But for measles, that's not the case. It's highly specific to humans. There's no animal reservoir. There's no environmental reservoir, as there is, for example, for polio virus, which is also a human virus. But the polio virus can persist in sewage, where there's fecal waste, because there's enough living cells, I guess, to allow the virus to replicate. But measles doesn't have an environmental reservoir either. It has to be spread from person to person, and if you can interrupt the human-to-human chain of transmission, it dies.
Can I ask kind of an involved question?
Sure.
Because I've just been talking to parents
Mhm.
casually
Mhm.
about, vaccines and everything, and I didn't know if this was factual. A lot of parents tell me, well, I'm not going to do this vaccine, not so much because they're anti-vaccination, but because they want kids to build immunity on their own. Is that a thing that people's immune system becomes stronger if they become infected? I mean, is that accurate or is that a misperception?
If it doesn't kill you, it makes you stronger.
I mean, that's basically what they tell me. I mean, to me, it's,
No.
your kid might be okay, but they can spread it to so many
The
other
measles
people.
vaccine confers lifelong immunity. So it's no different from natural immunity, except that you don't have a
But
disease
is
or
it
run the
true that
risk.
your immune system becomes
No.
stronger? I mean,
No.
when parents say,
No.
I want my kid to build their immune system on their own, that's not a factual process
No.
that occurred? Okay.
No, it's not.
Because I hear it so much. just
It's
from-
not. And it's not. And I'm
Yeah.
not an expert on what people think, really. But what comes to my mind in response is saying if that were true, then I would think that parents would want to get as many vaccines into their kids as possible, because with each one, a different part of the immune system is going to be stimulated,
Mhm.
So, even to diseases that the kids might not become exposed to, if that is the thinking, then I would think that exposing kids to a wider range of diseases through vaccination would contribute to making their immune systems stronger. But the immune system's pretty specific. It's not having a stronger immune system protects you, with the exception that there are people with immune deficiency diseases who are who can't mount immune responses.
So can I sort of expand on the question a little bit? Clearly, as you described, with something like measles or other serious diseases that are protected with vaccines, we would want to get the vaccine and stimulate the immune system. But what about, people talk about building your child's immunity just to the common cold by, for example, sending them to preschool. And this allows them to be exposed to all these viruses and so forth, and so they develop some immunity to bunches of different viruses, and that can be helpful. As you get older, you get sick less. Is that?
Well, kids are going to be exposed to a lot of things, and each time they're exposed to a virus, a bacteria that causes illness, there's going to be an immune response, no question.
Right.
By being when we vaccinate, what is a vaccine? It's really a weaker form of the disease that stimulates the same level of immunity. So they're much safer than allowing kids to be exposed to the natural illness. The vaccines don't have those complications that I showed before. So I know that there are people now who are holding measles parties and intentionally exposing their children to measles, and that it makes no sense to me at all. And when there are chickenpox outbreaks as well, people have chickenpox parties, so they have sleepovers at the home of people who have chickenpox. It just doesn't make sense to allow children to be exposed. Sorry?
People are doing that now.
People are. I've seen in the news.
There was.
Yes, I've seen in the newspapers that people now are holding measles parties
Well,
in
that
those
wasn't quite
communities
corroborated.
that are not, huh?
They've been posted
They-
on
Not
Facebook,
corroborated.
though, where
They've
they're
been
inviting
posting,
people.
but I haven't been able to verify.
Okay,
I've
I
looked
don't.
into it a lot.
Okay, I don't know.
Yeah.
I've only
And
seen.
the Department of Public Health in California issued
Yeah,
something about
right.
it. It's something they're concerned about.
Right. And so it makes no sense when the vaccine is an attenuated virus. It's vastly weakened by passages through many cell lines. Let's talk a little bit about that. And it induces the same lifelong immunity, and it confers the same lifelong immunity on the recipient as that person would get if they got the full dose of infective virus. So it doesn't seem to make sense to take the risk of, the measles vaccine is measles virus. And so I don't understand why people would want to intentionally expose their children, for example, to the stronger virus when they can expose them to the weaker virus and induce the same lifelong immunity. That seems to be taking undue risks. So I have to say, obviously I have a very strong bias, but I don't understand a lot of the reasoning if it's on religious grounds, okay. But if it's, I don't even know a lot of religions that don't promote vaccination, because most religions do try to provide protection to children. But I don't understand. There's no science. There's no scientific basis for exposing a child to a potentially deadly disease, or one that can cause blindness or deafness or pneumonia or so on and so forth, when you could expose them in a controlled manner to a lesser form of the virus that induces the same immune response. So that's basically what I want to say about that.
What is it that the person who has been vaccinated or exposed naturally has a disease
So they develop
that's
antibodies.
in their body that remains there? It's an antibody, right?
Yeah.
It's not the vaccine. It's not the virus itself.
No,
it's
you
an
develop
antibody.
antibodies, right.
How, since you mentioned there's no reservoir, no natural reservoir,
Mm.
how does it happen that the disease comes and goes in a population, even an isolated
It doesn't actually come and go, and if we were able to isolate these discrete chains of transmission that I was talking about, one could be able to trace every case to a source case, and it just keeps going around and around the world. People travel, and in that incubation period, the 4 days prior to the development of rash, people are infectious. And that's the way it keeps going. It keeps going around and around from person to person. On the Faroe Islands, it was because there was an introduction. There's no spontaneous occurrence of the disease at all. There are chains of transmission that if we were good enough and smart enough, we should be able to isolate them. But because we can't isolate them and then say we're going to vaccinate only those people who have been in contact with a source case, the policy, the strategy we've adopted is to try to vaccinate almost everybody. And by doing that, I guess I should talk about another concept that's come into the vernacular, and that's called herd immunity. And I should say, I guess, a word about that. So I really tried to look at, because it's such a simple concept, and I really tried to find the simplest slides I could to demonstrate it, because some of them are a little complicated. So I thought this was simple enough and something that even I could draw, although I did not draw this. But basically you have an infected, this is exactly what happens with measles. You have an infected person, this is the direct answer to your question, and that person gives the disease, if you will, to another person who becomes infected, and then that person gives it to another one and another one and another one. Except in the case of measles, this one would probably give it to 18 people are not. And those 18, each of those 18 would give it to another 18. And each of those 18 would give it, and so on and so forth. So that's the way it spread so rapidly. Herd immunity says that if you have an infected person, if that person is surrounded by 18 protected people, 18 people who are not susceptible to becoming ill because they've been vaccinated, for example, then it's like there's a wall that's built around that infected person and the disease can't spread. So that this person who's immunized will not get the disease and therefore will not be able to infect other people. So even if these people are not vaccinated, they can be protected. Right? So that's the principle. It's just a probability
Protected
equation.
from exposure, but not protected from infection.
No, if they were infected, they would get ill. They would get the disease. So the idea is that they would not be exposed. Exactly. So it's just a probability equation, basically. There are fewer people with herd. If you vaccinate almost everybody, then almost everybody will be like this person, incapable of becoming ill and incapable of spreading the disease. Almost everybody. So that's what herd, and therefore many of the remaining unvaccinated people would be protected. So it's just a question of probability. And I don't know what the herd immunity, the proportion of people in a society who need to be vaccinated against measles is. I suspect it's over 90% because it's such a highly communicable disease. But there's all kinds of mathematical models that give different levels of vaccination coverage that are required to have a herd immunity effect against this or that disease. It's an interesting concept, but it's one that's challenged in some of the literature that I've seen, and even by and then I've seen articles in the literature that say that, now they're talking about herd immunity, so they're treating our children like cattle. What? Really?
So the implication of what you said earlier about the fact that there's no reservoir outside of humans, the implication is that at some point, if we vaccinated enough and treated, we could eliminate this disease from the face of the earth.
Yes.
That would be possible.
Yes.
That's not possible with all diseases, but measles is one where we could really.
I'm going to come to that soon. Measles is and before the global health authorities settled on an attempt to eradicate poliomyelitis, polio, which is ongoing and approaching the end stages now, there was a big debate after smallpox eradication as to what the next disease should be that we try to eradicate, if one were to assume that that's a good thing to do. And measles was high up there. And in fact, there is a measles elimination program. And measles had been eliminated from this hemisphere, in fact. So the problem with measles as a candidate for eradication is its extremely high communicability. Polio is not a really good candidate for eradication because of its environmental reservoir, because you can eliminate it from humans, but it still can survive in the environment for a period of time. So it's really hard to eradicate, although we've been very successful at doing it. And there's only a few cases left, relatively speaking. And hopefully eradication will be achieved sometime in the next year or two. The problem with polio eradication now is us. It's not the disease and it's not the vaccine. It's that the last place where there is polio is in the northwest frontier province of Pakistan. So the vaccination efforts are being impeded by conflict, and if you saw over the weekend, there was a polio vaccination team killed not in the northwest frontier province, but in Baluchistan last week. And the Taliban and some others, Boko Haram and others, believe that vaccination is a plot by the West, and that whatever we say we're vaccinating against, we're really trying to do population control in Muslim. I mean, people have beliefs that we think are wrong. I have to say on the polio front, to digress, that the CIA vaccination campaign in Abbottabad, when they were attempting to obtain DNA from members of Osama bin Laden's family, didn't help to win over the hearts and minds of the Pakistani population. So we sometimes are thorns in our own sides in that regard. Let me move on. There's a man named John Enders who won the Nobel Prize with two of his colleagues. He was the leader of the team. He developed, first of all, he developed polio vaccine, which was further developed by Jonas Salk and Albert Sabin. But Dr. Enders was not happy with the way that the polio vaccine was rolled out. And in fact, I don't know if you're aware, there was a major accident following the beginning of the polio vaccination era, which I remember quite well because I was in one of the trials as a kid growing up in New York. But the Jonas Salk's polio vaccine is an inactivated or killed vaccine, not like the measles vaccine and not like the Albert Sabin's polio vaccine. And there was a laboratory accident where the vaccine was not adequately inactivated, and in fact, a large number of children got polio from being vaccinated, and Enders was really bothered by that. He hadn't played a very hands-on role in the commercialization and rollout of the polio vaccine, so he did do that with another vaccine, the measles vaccine that he developed with colleagues. And measles vaccine was first used in the United States, licensed and used in 1964. And here's an example of it. Measles vaccine now, we call it MCV, measles containing vaccine, because it comes as measles vaccine, as measles rubella vaccine. Rubella is commonly called German measles. It's another viral disease with no relation to measles at all, but a rash disease. It comes as measles rubella vaccine, and it comes as measles mumps rubella vaccine in that combination as well, which is the most commonly used in the U.S. now. So so we call it MCV, or measles containing vaccine. It comes in those three forms. And this is really, this tells the whole story, basically, this slide. So here's measles cases. I really don't know why there's such fluctuation like this. It has to do probably with the fact that when there's a huge outbreak, then there's more basically immunized or protected people in the population. So the next year there's not as many susceptibles around until the cohort builds up again of a susceptible population, and you get another spike. So this is the pattern. Now we're looking at hundreds and hundreds of thousands of cases occurring in the United States, and at a time when surveillance wasn't that great either. So these are undoubtedly huge underestimates. In 1964, measles vaccination began, and measles was done. I mean, you can't have much of a greater impact than that of a, but we see it again and again. And recently we've seen it with the introduction of a vaccine against a form of pneumonia and meningitis caused by a bacteria called Haemophilus influenza type B. And we've seen it in countries after the introduction of a vaccine against the pneumococcal bacteria as well. It just knocks the hell out of these diseases, and they go away as public health problems. So we didn't quite reach zero here or here, and what happened, there was another peak. Now this is a peak in 1980, in the late 1980s. It corresponds, so you can see that measles basically went away, but then every couple of years there'd be another outbreak, another outbreak, another outbreak. And after this one, the folks at the CDC and its Advisory Council on Immunization Practices got tired of having these spikes of measles as susceptibles built up every once in a while. You can see the numbers here are much, much smaller, but in 1989 there were 25,000 cases of measles reported, and what happened was that the public health authorities said, okay, we know that the measles vaccine is not full, it's not 100% effective, it's only about 92, 93% effective. And they said what we're going to do is require a second dose or recommend a second dose of measles vaccination. The first dose of measles is given at 12 months of age, and the second dose is given usually on school entry, and most states have laws requiring measles vaccination prior to entry of children into school. The second dose then raises the effectiveness of the vaccine to about 98%. And what that did was the introduction of the second dose allowed for the complete elimination of measles, and measles was declared eliminated in the United States in 2000, the year 2000. There were no cases, except for imported cases. There were no secondary cases. There were only imported cases, and maybe a few smatterings of, of transmission to people who are unvaccinated. Every once in a while, there are chains of transmission that develop because there's the introduction of measles into an Amish community or another religious community that has objections to vaccination. The current outbreak is occurring not in people who necessarily have religious objections to vaccination, but people who claim personal exemption, personal beliefs. They don't believe in vaccines. So some states allow this. The state laws vary in their permissiveness as to who's allowed to opt out of vaccination and who isn't. I saw an article that said that, and again, I'm not an expert in this area, but it said that if you plotted where cases of measles were occurring, that at the center of most of these little outbreaks of measles, there was always a Whole Foods, grocery store, because, So I thought, very well could be, very well could be. So anyway, here's this depiction again: measles incidents in the United States. This is on a per 100,000 cases per 100,000 population, and I mean, there's nothing to say. I mean, this is an unbelievably highly effective public health intervention that basically eliminates this disease as a public health problem. And that's pretty good. Now, I want to just say that in developing countries, the situation is quite different. It was, at any rate. And I like to show this slide because this is in refugees, and this is, Linda mentioned that I worked in Somalia in the late 1970s, and this is a slide that shows data from Sudan. You're familiar with the We Are the World, the song, and I was always struck that when that song was made and when some of the photojournalists put out their photographs that were picked up and went around the world, and there was a response to this refugee crisis, the pictures that we saw were pictures of starving children. And everybody knows that there's a lot of starving babies in Africa and blah, 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 and in these kinds of situations, and that's what people respond to. But in fact, the cause of death in these children was not malnutrition, it was measles. And it's just remarkable to me, and I asked the question as to how in 1980 and 1985, in these settings where all of our emotions were tugged at, all of our, we wanted to do everything we could to help. And so we were sending food and we were sending medicines and so on and so forth. But there was a perfectly good measles vaccine on the market, safe, effective, cheap, since 1964. And it was not used in a setting where the leading cause of death in these populations, more than half of the deaths were due to measles. So it's just a major mistake that was made, and myself and colleagues of mine took to the campaign trail after acquiring and analyzing this data and insisted that moving forward that one of the earliest interventions in humanitarian crises needed to be mass measles vaccination. And now that's current policy, and we don't have this kind of problem anymore. So you'll see a lot of the times UNICEF is doing a mass measles vaccination campaign, or WHO is supporting it, or whatever. So measles is much less of a problem everywhere now. So I just wanted to maybe say a few words about measles in the world. It's one of the leading causes of death. Even today, with higher vaccination coverage levels than ever before, measles still constitutes more than 1% of all childhood mortality in the world. So that's 150,000 deaths around the world, even with high vaccination rates. But In 1980, there were 2.5 million deaths of children from measles. In 1980, even though we had the vaccine in 1964. So it's not a science problem, it's an implementation problem, really. But it's down considerably because of efforts now to vaccinate all children around the world. And 75% drop just in this century. It's estimated the vaccination coverage now globally with measles vaccines about 85%. Not high enough to induce herd immunity, if you will, and probably the only way we'll get rid of measles is by vaccinating everybody. It's a really communicable disease, as we said, and you have parts of the world where there are adults who get measles because they don't encounter it. They don't encounter it at a younger age. So it's really effective, and since the start of this century has saved over 15 million. Here's a slide I wanted to show just again to show that there's such a strong correlation between higher vaccination coverage and lower incidence of this disease. And I wanted to say something about vaccines in general, because we can see this with every disease. Higher vaccination against pertussis or whooping cough, a tremendous decrease in the incidence of disease. Vaccines are really one of the best maybe public health tool that we have. This is a slide that shows, sorry it's a little fuzzy, but it shows the childhood vaccine, the standard childhood vaccine, 3 doses of a vaccine that protects against diphtheria, tetanus, and whooping cough. And we're up in different parts. Well, there's a tremendous difference between the vaccination coverage that's achieved in Africa and in the Western Pacific, for example. So, but it's a really important program. We have a whole organization called Gavi, used to be called the Global Alliance for Vaccines and Immunization. Now it's just called the Gavi Alliance. That many might remember earlier this month, there was a pledging conference in Berlin, and the donor nations of the world gave over $7 billion to Gavi, more than exceeding its own request to further efforts to spread vaccination around the world, because it's just been shown incontrovertibly to be an extraordinarily effective public health intervention that saves lives. What are vaccines? I just wanted to put my cow picture here. So in 1796, a young girl named Sarah Nelms got a rash on her fingers. And she went to see her doctor, who was this man named Edward Jenner, a physician in rural England. And he was a pretty good doctor, and he asked her what she did, and she said she was a milkmaid. And he knew that milkmaids were very susceptible to a disease called cowpox, where they would get blisters on their fingers. And he was wondering, because there was an epidemic of a very dangerous disease called smallpox, and it looked kind of the same, but it was only on fingers, what he could do to, if there was any relationship between the two. So he took some pus from one of the blisters on the finger of Sarah Nelms, and he grabbed this kid who was passing by, basically, as I like to say. There was a kid walking by, and he grabbed him, and he inoculated the pus from the girl's blisters into this child, and then exposed the child to smallpox. When, you know, they didn't have institutional review boards at the time, so whatever the ethics of it were. But the kid was protected and did not. And so Jenner was able to say, hey, I took this stuff from this girl with smallpox and put it in this boy, and he didn't develop with cowpox, and he didn't develop smallpox. So there's a number of things that we can draw on from that. First of all, Jenner's the father of vaccination. This is the first time a vaccine was used to protect against smallpox. I could say a little bit more about that, because for centuries people had been taking pus from the pustules of smallpox patients and using it to inoculate other people. But some of them got smallpox, a lot of them got smallpox. But here Jenner took a this is really an interesting story, because smallpox vaccine, unlike measles vaccine, which is a lesser form of measles, an attenuated form of measles, the vaccine we use against smallpox is a totally different virus. It's a virus that's related to, it's a virus that causes an animal disease that's related to smallpox, but it's not smallpox, but it induces protection against smallpox. So that's an interesting kind of thing. I'll run through this. I just want to finish up by, So this is from a disease called smallpox. I wanted to put that picture of the cows up again because what is a vaccine? Vaccine is from the Latin for cow, right? Vacca, cow. So it comes because it started with the cowpox vaccine. That's where the word comes from, in fact. So that's the etymology of it. Now, I just wanted to finish by saying what the potential power of vaccines is, and you mentioned it, Linda, already. Smallpox, a disease which was a scourge of humanity for many, many, many years, and has played a role in altering the history of our species in that smallpox was a very useful, it's been used as a biological weapon many times in the past, and a lot of the Spanish conquest of the Americas was due to their introduction of smallpox into naive populations, and it spread amongst the Native American population the same way that measles spread in the Faroe Islands. The Revolutionary War had a number of instances where the British would hand over as gifts blankets to Native Americans that had been, what would I say, infected with smallpox scabs, and spread the disease and helped win battles that way as well. So at any rate, it has a big historical impact. But in 1980, the World Health Organization declared smallpox eradicated from the face of the earth, and it's just not around anymore, except for there being samples held in 2 laboratories in CDC and in Russia. But this is a disease that we don't worry about. We don't vaccinate against it anymore. We take no precaution. It's gone. It's dead, and it's not the only it's not the only disease that's been eradicated. I mentioned very briefly earlier a disease called rinderpest, which is a terrible, terrible disease of animals. This is from the 15th century or whenever, I don't know, in Holland. But this disease really was a great impediment on the development of economies in Africa, livestock economy in East Africa in particular. But in 2011, rinderpest was declared eradicated by the Food and Agriculture Organization. It was eradicated because it's a highly effective vaccine, and the vaccination strategy that was used was able to protect cattle from the spread. And why do I mention it in particular? It's the second disease that has been eradicated. But like canine distemper, rinderpest is a measles virus. So it's just the same. It's measles it's in the same family. It's basically measles of cattle, if you will. Again, measles is highly specific to humans. The viruses are separate enough. Vaccination with rinderpest would not protect humans against measles. The viruses are too far apart genetically. But it is possible to eradicate diseases using vaccines. You're getting nervous, so I'm just going to stop. And I don't think I have. That's not important. So just let me say in finishing, just that when the World Health Organization started a program right after the eradication of smallpox. Smallpox was eradicated using a vaccine, cowpox vaccine. It was so successful that the World Health Organization, with the help of the CDC, most of the people involved were from the CDC, immediately began what's called the expanded program on immunization. So it went from smallpox vaccination to trying to reach all children with a battery of vaccines. Now at the time, there were only 6 vaccines that existed for routine childhood immunization: diphtheria, pertussis, tetanus, BCG, which is a tuberculosis vaccine, which doesn't work really well, polio, and measles. Now, since that time in 1976, when the EPI, expanded program on immunization, began, we now have 25 vaccines in our public health armamentarium, and probably more, but these are ones that can be and maybe ought to be in common usage. And they protect against a wide range of diseases, like measles, anthrax. You can see what they are. 25 vaccines. I want to point out that some of these vaccines protect against cancer. So there are infectious causes of cancer that we know about. Human papillomavirus vaccine, HPV, again, towards which there was tremendous objection as well when it was introduced in this country, but this is a vaccine that protects against the most common causes of cervical cancer, uterine cancer, which is a leading form of cancer in many parts of the world. Yeah.
I'm going
Sure.
to interrupt for
Go
1
ahead.
minute, and you guys can continue and you can ask your
Um,
questions. I apologize, I just have to zip into the studio because we're going to be starting there with
Yeah.
our next guest.
Yeah, okay.
So I want to tell you, present you with this
Coffee
Evelyn
mug.
Y. Davis Studios mug, and thank you
Thanks.
so much
Well,
for
thank you.
being here. And I
Thanks.
want to let all of you know that at 10:30, our next guest is going to appear first on this screen from the studio, and that'll also be a live webinar, so there will be people outside of M.P.H who are watching via the web. But after 30 minutes, she will be coming in here, and you'll all have an opportunity to question her in person and to hear what she has to say. So this will be a kind of split session. But before that happens,
She's great.
do you have a break? Someone, who's got the agenda there? Okay, so yes, you will have a break until 10:30, and then 10:30 we'd like you to be back here. So I will see you all at 11.
If you all have questions for Dr. Waldman, why don't we take questions for another 5 minutes or so?
Yes, absolutely.
I'll
And
keep my
thank you
answers
so much,
short.
sir. I really appreciate it.
Thanks. Told you I get very lectured.
So I have kind of another anecdotal question.
Sure.
I know that a lot of parents will kind of be a little bit overwhelmed with how many vaccines kids have to have. What is the total now? I mean, before kindergarten? It's all that, okay.
This is
So
the
what-
schedule.
how many
This is the vaccination schedule. So.
Okay,
So there's 1, 2, 3, 4, 5, but this is all in one shot, right?
okay,
But
yeah.
1, 2, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15 diseases against which we routinely vaccinate.
And, but a lot of them have, even the MMR vaccine has a booster shot, so I mean, how many
Some of them.
how many actual shots are they getting?
Well, they're all on here. I didn't count them up. So here, like here, the MMWR is 2. Varicella vaccine has a booster also. DTP has 1, 2, 3, and 2 boosters. So the hepatitis B
there's a
series.
lot.
A lot. It's a lot of vaccines.
And I mean, should doctors be recommending against pushing back certain vaccines? You know, if parents say, "Oh, let's just do one shot today," should they?
There's no reason
insist?
for it. There's
Yeah.
really no reason for it, you know. And I once was on a group of people. They took us to Paris Island, where the Marines are inducted, and it's just pretty remarkable. They line them up, and they have guys on both sides of them with these jet injectors, and they walk down the line, and they get, God, I don't know how many vaccines they do, but they're Marines, but it doesn't do them any harm,
They're not
you
Marines
know.
when that
It protects them. But
They're just kids off the street
Maybe.
who are being processed. It is quite my particular favorite part of that is the gamma globulin, where you drop trowel and back
Yeah.
up to 2 guys who stand in both cheeks.
It was quite a day and an interesting scene. And then you ask them afterwards how they tell. But yeah, there's no danger to it. And honestly, I think it's worth recommending. I can understand why parents would
Yeah, I mean,
find it
kids cry,
intimidating.
whatever.
Would find it intimidating. But this is really our best scientific knowledge of the day. And I think that's a good question to ask Ann Shuckett, because you know,
Yeah.
she's in charge of all
'Cause I
this
just
for
feel
the
that
U.S.
I understand the anti-vaccination movement is problematic, but I don't think that as many parents are that adamant about the actual, let's get a vaccine versus maybe trying to be a little bit more flexible about it.
Well, okay, ask Ann. I mean, I think that's it's a good question. I think that, when we talk, the anti-vaccination movement is not monolithic, I don't think.
Yeah,
I think
agreed.
what people like me react to is this, a lot of the people who try to, who and it's interesting because I saw this with Rye's syndrome also. When you have a kid who's sick or not well from one condition, you really try to find a reason for that and an explanation. That people latch on to reasons. And this article that was published by Wakefield on the association between vaccines and autism really was something that I try to be careful. You're all journalists. I don't want to say the wrong thing. But it just did a lot of harm to the public health movement. I think there's a natural tendency for parents who might have children who are autistic to try to find a reason, an explanation for that. And if if a reputable scientific journal like The Lancet publishes a paper like that, that establishes that association, you can latch on to that very, very strongly and have difficulty giving it up, even when the article is withdrawn because it was all fabricated, basically.
In one of my pieces, I even looked at the different age groups for those who were infected, and a lot of those who were infected were born after that paper was published, after
Yeah.
they started public health
Yeah.
measures to vaccinate everyone. I, for example, I'm 28. They would have started vaccinating me in kindergarten, but I grew up overseas. I'm not positive I had the second vaccine. My parents
Right.
weren't either. I got it last week.
Good.
So I just
That's what
I
they're
just feel that
recommending.
there are a lot of factors that are going into this current outbreak. When you really look at the data that kind of show, okay, the public health measures work, so because we targeted kids, a lot of the
Well, that's
older
exactly
people-
right. And there have been
Yeah.
clusters of deaths that have occurred in different communities. I remember one in Tennessee. And people attribute that to a lot of the children involved had recently been vaccinated. So you just have to look at this vaccination schedule. Kids are getting vaccinated in almost every month. Everything that happens to a kid in the first 2 years of life is going to have some temporal association with a vaccination. And that's all it is this temporal association, because vaccinations are occurring so frequently, and bad things happen to kids less than 2 years old. That's the highest risk period for, things happening. So if you look for that kind of association, you're going to find it, because we're always doing it. The same as you might, there's many other things going on with kids, but vaccinations can be scary for parents, I imagine.
Thank you very much, Dr.
Hi,
Waldman.
I
Oh,
just have
make
a
it quick.
question. First of all, I wanted to just say there's a fascinating documentary that PBS produced maybe about 6 months ago on vaccines. That's pretty good. My question is, earlier you stated that a measles infection causes a decline in vitamin A in the body. And I wanted to ask you if there has been any research that has connected a prior measles infection to vision disorders such as the forms of macular degeneration or glaucoma, because as you know, they're being treated with sometimes high doses of vitamin A, and it causes optical damage.
So I think what I stated and what I would say most strongly is that there's a lot of evidence to be able to say that children with vitamin A deficiency get more severely ill with measles than others. Okay, now whether the measles virus causes vitamin A deficiency, I said that I think that it can that an illness like measles, others as well, can deplete liver stores of vitamin A, because when children are recovering from an illness, they need more calories and micronutrients than they might otherwise, because they have to compensate for the losses that they suffered during the illness. So kids with marginal vitamin A deficiency can be thrown into vitamin A deficiency state during their recovery from measles. So you have to give them more to keep up. You have to catch up with it. So the blindness that's caused by vitamin A can be either vitamin A deficiency induced or from direct infection of the optic nerve, for example, from the virus itself. So there's different forms of blindness that can result from vitamin A. The kinds of things you're talking about, the macular degeneration, I'm not aware of. I don't. It's not my field.
You're not aware of any research that's kind of connected a prior.
I'm not. Only to say that vitamin A deficiency is a cause of blindness. It causes a condition called keratomalacia, and vitamin A supplementation is routinely given with vaccination campaigns in developing countries, only because large proportion of the population is vitamin A deficiency. So it's a way to boost their vitamin A stores.
Thank you, Dr. Waldman.
Okay, thank you.
very much.
Thanks.
Okay, just a few minutes before the webinar is going to appear on the screen, but if you need to take a quick bathroom break, the bathrooms are down the hall to your right.